I'd love to introduce Steve now, a vascular surgeon, head of vascular surgery at MedStar Health.
I will come off mute before somebody accuses me of having Dr. Dexter level Zoom skills. So it's hearing everything that's been presented so far. There's generally a consensus that we need to remove CLOUT based on this open vein theory. We have a new set of devices, particularly ClotTriever, which has a large registry of data that we can pull from to demonstrate that the device is efficacious in making people feel better by removing thrombus and reducing their Volta score. But the question becomes, how do we put this data in context with previously published data, and where do we move the needle in terms of either our own institutional guidelines or societal guidelines for understanding the indications for intervention? Because the goal of all of us is to really function in an evidence-based world. And so what we can do is take the repository of data from the CLOUT registry, and Inari was great as an organization and a company by being the first to analyze the raw ATTRACT data outside of the ATTRACT investigators and do a propensity score matched analysis of both data sets to get an idea of how the device or mechanical thrombectomy device would compare to previous iterations of forms of clot treatment, mostly being lytic, radiolytic, pharmacomechanical. So this is a propensity score matched analysis of early clinical outcomes from the CLOUT and ATTRACT studies. Now, as a reminder to everybody out there, ATTRACT is our fundamental reference trial in the United States, and I think globally, for guiding intervention for DVT, and it's the most cited trial for clinical guidelines and how societies are addressing level 1 or level 2 evidence for generating those guidelines. But it's been referenced in the question, ATTRACT showed no benefit over anticoagulation unless there was subset analysis, particularly looking at those patients being treated for iliofemoral DVT and their likelihood for having severe post-thrombotic syndrome. And as we mentioned before, ATTRACT was run over a long period of time, but prior to the use of specifically designed mechanical thrombectomy devices like the ClotTriever system. So we were able to take that data from the CLOUT registry that has looked at the safety and efficacy of the device, as well as the clinical outcomes of the device through a extended period of time, and then compare that to the full ATTRACT data in a propensity matched analysis. For those of you who are very familiar with propensity matching, you're going to say the next slide is very boring. For those of you who are not, you would be like me, constantly needing a refresher or an update at times. So what this means is we took all of the patients in the CLOUT registry, a prospective multi-center observational registry, and that was about 499 patients in total, and we looked at their data through 30 days. And then we looked at the ATTRACT trial raw data, a phase 3 multi-centered randomized controlled clinical trial run from 2009 to 2017, and essentially looked at the 337 patients in the interventional arm, meaning that they were randomized to intervention and also had follow-up to 30 days. From both of those groups, the 337 in the ATTRACT trial and the 499 in the CLOUT registry, we dropped any patient that did not have incomplete data. On the CLOUT registry, because you could have bilateral disease for the registry, but you could not have bilateral disease for the ATTRACT trial, we dropped those patients with bilateral disease. And because the CLOUT registry is an all-comers registry, as Dr. Dexter made reference to, we had to exclude patients who had symptoms of greater than 4 weeks because those patients would not have been a lytic responder or enrolled in the ATTRACT trial. So ultimately, that left us with 153 patients that met those criteria between the two trials and could be matched on 11 baseline covariates. So we were able to look at 153 pairs of people who were similarly situated between the CLOUT registry and the ATTRACT trial. For those of you interested in statistics, it's my favorite term. This was a nearest neighbor greedy match, and it had a standard caliber deviation of 0.2. And so when we look at those baseline characteristics for which the patients were propensity matched, we looked at age, gender, BMI, the laterality of the leg, whether or not the patient had had a previous DVT, their ethnicity or race, and their symptom duration. So these are our first cohort of covariates that were analyzed. So unmatched, those patients had statistically significant difference between the groups. Once they were matched, we were able to eliminate the statistical significance, making it an appropriate propensity matched group. And again, our last four sets of covariates that we looked at were the location of the DVT, whether the patient had isolated iliofemoral or isolated femoral popliteal or iliofemoral with inclusion of the femoral popliteal segment, whether the DVT was provoked in nature, and what their baseline Volta score was, as well as the Marder score. And I would remind you, in both ATTRACT and in the CLOUT registry, it is a core lab adjudicated Marder score. So this was not a provider-provided Marder score for the CLOUT registry patients. So again, pre-matching this unmatched group, the p-value was significant. Post-match analysis, this was an insignificant pairing. So when 153 people, we were then able to do some comparison. I would point out that even after matching, there were some statistically significant differences, but they would be kind of as we would expect. There were differences between the two groups in the number of single session therapies, which we would expect. The ATTRACT trial primarily focused on lytic-based solutions, and for the most part, those lytic-based solutions took place in 2 interventional suite visits. And the use of TPA was statistically significantly different between the two groups. In the CLOUT trial group, only 1 patient required the use of TPA. In the ATTRACT group, 149 patients required the use of TPA. But we also saw differences in the mean length of stay, meaning the procedure overnights, hospital overnights, as well as the use of the ICU. And again, with the higher use of TPA in the ATTRACT group, we saw in our propensity mass analysis that we saw lower ICU visits and lower length of stay in our patients who were in the CLOUT group. Interestingly enough, not a big difference between the incidence of venoplasty and stenting between the two groups. So from an interventional standpoint, what was done in the case and in that covariate analysis, we showed that these 153 pairs were essentially the same, and the differences were what would you would expect based upon the procedure being performed. So what happened when we looked at the two groups? Well, there was a statistically significant difference between CLOUT and ATTRACT when it came to Marder score reduction. CLOUT had a better Marder score reduction than those patients in the ATTRACT who were propensity matched. And this was significant to a p-value of 0.0001, 89.8% reduction in Marder score in the CLOUT patients, and a 69.5% reduction in Marder score in the ATTRACT patients. And when we looked at thrombus clearance in a tiered fashion, we saw that the statistical significance persisted. So when you look at all of the patients who were marked as having greater than 75% clot clearance, there was a statistically significant difference in the number of patients between CLOUT and ATTRACT with that result. 88% of patients in CLOUT and 66% of patients in ATTRACT. When you look for those patients who have greater than 90% of clearance by the core lab adjudicated Marder score, 61% of patients in CLOUT and only 42% of patients in the ATTRACT trial. And when you look for the core lab adjudicated Marder score reduction of 100% thrombus removal, 55% of the patients in the CLOUT registry had 100% thrombus removal, whereas only 30% of the patients in the ATTRACT trial in the same propensity matched group had 100% clot clearance. So we see this statistically significant difference in the response of thrombus to lytics as opposed to mechanical thrombectomy, with favoring results towards CLOUT and mechanical thrombectomy with ClotTriever. But what did that do for the Volta score, right? Because we believe in an open vein theory. We believe in the idea that clot resolution early on should result in improved symptoms for a patient. And we focus on a Volta score, which is a combination of both physician observed results as well as patient reported results. So in the CLOUT registry, at the 30-day mark compared to baseline, we saw a 57% reduction in Volta score. In the ATTRACT trial, it was a 48.9% reduction of Volta score with a p-value of 0.05. And when looking at Volta disease severity, when comparing patients with a Volta score of greater than 10, there was no statistical significance reached. For those patients with a Volta score of greater than 5, those patients in the CLOUT registry had a better outcome than those in the propensity matched analysis of those in ATTRACT, with a p-value of 0.05. So 24.8% of patients had a Volta score of greater than 5, compared to 39% of patients after intervention have a Volta score of greater than 5 in the ATTRACT registry. So one of the things that this brings up to question is actually something that I have been pegged by Rick on podium on, and have distinct memories of him walking up to a microphone and saying, "You cannot use Volta score to talk about 30-day or 6-month results." And it's a great conversation to have. So it begs the question, when you look at the ATTRACT results, which is a great RCT, can you take the data? Because PTS was measured by Volta score. Sorry, I should say, for specificity's sake, Volta score was measured at 30 days. Can you use the Volta score at 30 days to predict who would have PTS later on? And so we're comparing the results at 30 days in this propensity matched analysis. But when you look at the 30-day results from the ATTRACT patients and do an area under the curve logarithmic regression model, you can predict and use that 30-day Volta result to predict who is going to have elevated Volta scores at 6 months, 1 year, and 2 years with great specificity. And so for area under curve assessment, really what you're looking for is the closer you get to 1, means the more likely that the result correlates. And in these results here, when we see area under the curve of 0.8, 0.78, 0.8, really anything above 0.7, 0.65 is where you start to show that odds ratio is really favoring this association. And so when we say that there is a difference in results at 30 days in our propensity matched cohorts, we can also show that 30-day result based on the same patients from the ATTRACT trial, looking at area under the curve, logarithmic regression, is an appropriate marker potentially of PTS down the line, because we do see that correlation. So I would say, in conclusion, really propensity match analysis shows us that contemporary interventional strategies with CLOUT do stand their ground and have comparable, if not better, results than those patients treated with lytic-based solutions in the ATTRACT registry. And CLOUT demonstrates better thrombus extraction and improved 30-day Volta scores as a result. There's a 20% MARTA score reduction that's better in CLOUT subjects as compared to those patients in the ATTRACT trial, and 22% more subjects achieved complete or near complete thrombus removal. For 15% fewer CLOUT subjects had Volta scores at greater than 5 at 30 days. And the interesting thing then goes to the question at the podium is, well, does that matter? An analysis of the ATTRACT trial data looking at the 30-day Volta score measured shows a positive area under the curve association with future PTS as measured by Volta score at 6 months, 1 year, and 2 years. So I do think this has significant potential long-term implications in our understanding and validation of both the Volta score and on the positive impact mechanical thrombectomy with CLOUT can have on patients. So what do you need to do? You need to do more. This is going to be an RCT such as the Defiance trial, which is sponsored by Inari Medical. And this is a RCT comparing intervention with CLOUT versus anticoagulation alone. And very excited to announce that the first patient has been enrolled in the United States. And the goal here, in terms of the Defiance trial, these are 300 patients randomized 1-to-1, looking at symptomatic proximal DVT and looking at interventions led by the CLOUT system versus conservative medical management with anticoagulation alone. So 300 patients with iliofemoral DVT, I should say proximal DVT, randomizing to both the CLOUT intervention arm versus the conservative medical management arm. And they are going to be assessed at a 10-day visit, a 30-day visit, and a 6-month visit. And we're looking at a win ratio primary endpoint hierarchy, win ratio hierarchy primary endpoint, looking at the occurrence of treatment failure or therapy escalation, and the assessment of post-thrombotic severity as defined by the Villalta score at 6-month visit. So again, it's a 6-month trial, really looking at the comparison of anticoagulation to mechanical thrombectomy, and really the first big RCT looking at that since ATTRACT, and focusing primarily on a mechanical thrombectomy solution. So first enrollee, and we're out to races.